I'd now like to invite Dr. Asgeirsson to the podium to present implementation of colonoscopic process measures. Does it improve quality?
I would like to thank for this opportunity. Implementation of colonoscopic process measures, does it improve quality? The authors have nothing to disclose. I actually have to disclose that I'm from Iceland. I want to apologize to any European colleagues in here that may potentially be stuck in the United States, but it looks like most of them have left. This is an image that was taken at the beginning of the current eruption by a good friend of mine by the name of Guðni Hansen. The only good thing for Icelanders is that now they're reporting more on this than our tumbling economy. But the National Polyp Study and epidemiological trends have shown that screening colonoscopy and removal of clinically significant adenomatous polyps have reduced the incidence of left-sided colon cancer in the U.S. Since then, much emphasis has been put on adenoma detection rates as a quality measure for screening colonoscopy, and adenoma detection rates of 25% for males and 15% for females are recommended by continuous quality guidelines from the U.S. Multi-Society Task Force. There are some contradictions in using adenoma detection rate as a quality indicator for screening colonoscopy. And one of them is that the National Polyp Study showed a discrepancy between high adenoma detection rates and colorectal cancer incidence. And this can only be explained by the assumption of adenoma regression. And second, there is a high adenoma missed rates for polyps under 10 millimeters, and the clinical benefits of removing small adenomas is unclear. So strategies that focus on adenoma detection rate and withdrawal time may not be the optimal surrogate quality indicator for colonoscopic cancer screening. Now, multiple revisions have been made to continuous quality guidelines for screening colonoscopy, and in an attempt to guide intervals between surveillance colonoscopy, recent guidelines have focused on risk stratification. The emphasis of interval colon cancer has not been as high, which can be defined as a cancer diagnosed between surveillance examinations and has an incidence of 1.7 to 2.4 cancers per 1,000 person-years of observation. Interval colon cancer may play an important role in outcome-based evaluation of colonoscopic screening programs. The purpose of our study was to compare outcomes between colonoscopic screening prior to and after departmental implementation of a 6-minute withdrawal time. We looked specifically at polyp detection rate and adenoma detection rate during both time frames, and also specifically at the incidence of interval cancers in the earlier study population. All outpatient screening colonoscopies during the first 6 months of 2006 and 2009 were reviewed. Pathology reports were correlated with endoscopic findings, and a retrospective chart review was performed on all screening colonoscopies from 2006. Chi-square and t-test was used for quantitative and categorical data respectively, and confidence intervals were used to compare differences in proportion. Now, there were 900 screening colonoscopies performed during the first 6 months of 2006 and 750 screening colonoscopies in the first months of 2009. There was a slight age difference between the two time frames. Cecal intubation rate was around 97% for both time frames, and visualization was good in over 99.5% of the screening colonoscopies in both years. This slide shows just a graph of the distribution of the adenomatous polyps, and as prior studies have shown, they were most commonly found in the sigmoid colon, descending, and transverse colon. The adenoma detection rate increased by 2.4% between the two time frames, from 7.2 to 9.6%, but that did not reach statistical significance. And similarly to that, the polyp detection rate did not statistically change. What we did next was we broke the adenomatous polyps into size groups, and what we found was that there was a statistical increase in adenoma detection rate for 5 to 10 millimeter adenomas. And this next slide just shows graphically the size groups, and on the left side are the counts for each size group, and the graph shows the size groups, the percentage increase, And as you can see, from 2.6 to 4.8% in the 5 to 10 millimeter size group, and this did show statistical significance. A single cancer was diagnosed on post-polypectomy surveillance colonoscopy, and as per definition, this was not defined as an interval colon cancer. Now, looking at the pathology and the interval from the index colonoscopy, this clearly was a missed lesion on index colonoscopy, either a high-grade dysplastic lesion or an early cancer. Using current risk stratification guidelines of 5 to 10 years, this would be defined as an interval colon cancer. And our data would show an interval colon cancer incidence of 0.4 cancers per 1,000 person years of observation, which is much lower than published rates. In summary, the implementation of the 6-minute withdrawal time did not significantly alter overall polyp detection rate or adenoma detection rate. And despite adenoma detection rate of 7.2% in the pre-6-minute group, the incidence of interval colon cancer in the 3 years following was low. These results occurred in a population examined by experienced endoscopists with a high rate of cecal intubation and removal of clinically significant adenomatous lesions. And finally, when using colonoscopy as a screening tool, we have to be aware of several facts. One is that there are limitations of the technology in itself. There's high inter-operator variability. There's a significant adenoma miss rate in small polyps. And if we're going to use adenoma detection rate as a quality indicator, we need to be aware of the fact that non-neoplastic lesion increases as you increase your adenoma detection rate, and that increases the cost to your screening programs. But that being said, interval colon cancer rates and adenoma detection rates of large adenomatous polyps that have less variation, in addition to adequate bowel prep and success of cecal intubation, may provide a superior mix of process and outcome-based evaluation for colonoscopic screening programs. And I thank you for your attention. We'll take any questions.